Several of us have had an opportunity to hear Dr. Tuckson, and I think you will find him an engaging and equal opportunity provocateur. Join me in welcoming Dr. Tuckson.
All right. I like that idea of being an equal opportunity provocateur. Thank you, Cheryl. It really is a great pleasure to be with you. I'm going to really challenge myself and you by putting much too much information in much too short a period of time. So you're going to have to listen really fast, right? Because we have to do a lot of things if we're going to respond to the challenges of this moment. And I think that what Cheryl said is really key. This idea of employers being the catalyst to leverage change. And that was what made me really want to be with you. There is no question that this moment is a moment of volatility. It is a moment of instability. There is a moment of great risks. But like you, I'm private sector oriented. We see from the private sector, obviously, when you see instability, volatility, and risk, you see opportunities. And the opportunities are there for us to do something powerful and to make a difference. This is a moment that is ripe for innovation, new care models, but it is also a moment that is ripe for new partnerships. And the role of employers is absolutely key. The private sector leadership has been essential in stimulating and harnessing change. Let me just review for you the modern history. This is actually in November of last year. And I read this and I went kind of crazy. Nearly 1,500 hospitals penalized on the Medicare program rating quality. Medicare has raised payment rates based on 24 quality measures. For the first time, looking at death rates, and others are being paid less. And here's the thing that made me crazy. Across the country, hospital executives say they have put renewed focus on excellence in areas that they are judged. Renewed focus. So I went back and thought about how we got to that moment. And I started in 1995 with GE and Motorola and Allied Signal using Six Sigma engineering processes in running their businesses. That led to the formation of the Leapfrog Group in 1998, a group of large employers who came together to discuss how they could work together to use the way they purchased, sound familiar? How they purchased healthcare to have an influence on its quality and affordability. Immediately after they did that, the seminal report that changed everything came out in 2000. It was issued in 1999 and really published in the early 2000. And this is the To Err is Human report that really was the moment the genie came out of the bottle, because it told us that between 44 and 98,000 people were dying in American hospitals because of misadventures at a cost of $17 to $29 billion. And the private sector saw that report and went, what in the hell is going on? What are we paying for? And how could it be possible that you have that kind of a problem? And so the Leapfrog Group came out with its first hospital survey in 2001. And now it's in its fifth version. And so you see an article like this back in now 2013, and somebody is going to say, we're putting renewed focus. What have you been doing all that time? And so today, 1 in 25 patients gets an infection in a hospital. The quality of care delivered to patients within the same hospitals varies by insurance type. If you want to know what private sector leadership does, the real difference is inside the hospital itself. If you have private insurance versus public insurance, a significant quality differential. Somebody's paying a lot more attention to the privately insured people than they are to the publicly insured people. And then not only is the concern around what happens in hospitals, but the entire system itself. The year after the To Err is Human report came out, there was the seminal Crossing the Quality Chasm, whose definition, the cover of the book says it all. There is a chasm between the quality of care that ought to be delivered and the quality of care that is delivered. And now, the most recent in that series, it came out in 2012, which tells us that there was $750 billion in waste in the care delivery system. The physicians have come together. around their professional societies, and they've now told us that 30% of the care in the United States is duplicative or unnecessary. And now these 25 medical societies are moving together finally to try to address this. This has only been in the last 2 years or so. And so this really delayed kind of response. And now we are seeing that Medicare spending on prostate cancer, screening old men, completely inappropriate, wasting $447 million in expenditures. The American Urological Association says that routine PSA screening is not recommended in men over 70. We need to clearly communicate to our patients the benefits and risks of prostate scanning, but at the end of the day, the onus is now on clinicians to get their act together. And then finally, in the device industry, move out of the medical care, but to devices. Medical device recalls nearly doubled in a decade. And if that weren't bad enough, healthcare is getting to become really complicated. Get really complicated because the genomic era is now descending on us. We are now fully in the era of genomic medicine. And these are the curves for how much money is going to be spent just in genetic testing. I want you to really be thinking about where the puck is going here, employers, and where your colleagues are going to be confronted. The number of genetic tests that are moving through the system now is increasing at logarithmic rates. We will spend somewhere between $15 and $25 billion by 2021 on genetic-based tests. I used to be the chairman of the Secretary of Health's Advisory Committee on Genetics for many years. And I remember just the briefing books that we would have. When we started out, they were very small. And when we finished 6 years later, it was the size of Manhattan telephone books. But look at this chart. What you're seeing on the vertical axis is that on the left is the number of facts per decision. On the right, the increase in the genomic sophistication. What is not, and the number of facts per decision, again, is logarithmic in its increase. What is not increasing is the black line, human cognitive capabilities. Unless you all have invented in Wisconsin some kind of special milk that makes you smarter and makes your brains expand, we're not any smarter than we've been. And so the notion is going to be, how do we make sense and process all of this information to make the right decision? We need your community to keep the pressure on. Just like you did with Leapfrog, just like you did when to areas human is coming out, people still don't get value. And so you can't take your feet off the gas, especially because of this. And you understand this concept, but I want to make sure you really understand this concept of how pervasive this notion of rising costs are and how intense it is getting. Your colleagues in America, your fellow citizens, are beginning to see this chart that tells you the relationship between expenditures and life expectancy, and now they see where we are. It makes no sense that we could be that far out of whack. What are we spending our money on? And what is the ROI on our national investments? The chart on the left is a busy one. I only want you to look at the top two curves on the left, and I want you to see the slope of that curve. The slope of that curve represents two things, those two top curves: physician-provided directed care and hospital-delivered care. The slope goes dramatically up and very rapidly. The other things are important, like durable medical equipment, pharmaceuticals, long-term care. Those things are important, those other lines. But what's really driving the cost explosion is physician-directed and hospital-directed care. The slope of that curve is absolutely unsustainable. The chart on the right sort of extrapolates from now out into the future. And what it basically says is if we don't get control of this, you get to $4.3 trillion of expenditure. Now, you know, as private sector purchasers of health care, there is no way this country is ever going to get to $4.3 trillion of expenditures. It can't happen, which means something dramatic has to happen to stop it. Well, it's not just the private sector that's concerned. It's also what happens with the public sector. This is the famous bending the cost curve slide. Whenever you hear people talking about, we got to bend the cost curve, this is where it came from. This happened when President Bush II, the younger, was in. And if I could do the Texas twang the right way, I would, he said, ladies and gentlemen, we've got a Social Security problem here in America. It's the best I can do. I've been practicing it. I can't get it. But you get the point. And the Congressional Budget Office said, hey, dude, I don't think they actually called the president dude, but probably something more along the lines of, Mr. President, sir, Your Honor, Your Majesty, you don't have a Social Security problem. You got a Medicaid and Medicare problem. And you know and I know there is no political climate that will ever allow enough tax increases to satisfy the slope of that Medicare curve. It can't happen. Even if you got a little bit of tax increase, it won't be anywhere near enough to take care of Social Security and Medicare and all the other stuff that's going on. Something has to hammer that Medicare curve down. There's nowhere else to go. And what you are seeing inside of government today are massive sledgehammer-like efforts to hammer down that CMS expenditure. But what you also know here in the great state of Wisconsin, or any other state that you go to, every governor in America is in deep doo-doo over the Medicaid budget. Why? Because of this. This is the difference between, on the rising side, Medicaid, and on the decreasing side, K through 12 education. We have taken away our children's future because of our expenditures on the public sector side for health care. It can't keep going like this. Look at K through 12 education. This is our children. And these are the trade-offs that are happening in American life. So very, very severe consequences. Well, if you can't get it from the feds, and you can't get it from the private employers, especially the ones with global economy, global competition, and you damn sure can't get it from the small business owners, and if you can't get it from the state, where can you get it? So the price increases come out of Mrs. Jones's pocket on 43rd and Vine. That's where it's at. And that's the escalation in out of pocket, and the bottom curve is wages. Anybody in this room think wages is going to go up and compensate for that delta? Even with you got the wage increase for low-income workers that is being the source of the political fights today. So when we are worried about increasing costs, we're worried about Mrs. Jones. There's no magical person anymore, and America now begins to get it. Is there a permanent slowdown? We see a slowdown happening, and that was the good news, and that was exciting. What you got was a finally reported that the growth of health expenditures was lower than the increase in GDP. And that was, people were pretty excited. Probably the reason is because of the recession. Every time we had a recession, we noticed that there's a drop in healthcare expenditures because out-of-pocket discretionary choices go down. And so that may have been good. The real reason I think that's underneath the slowdown was the people who are managing healthcare costs on your behalf all across America. They're throwing every tool in the toolbox at it. Medical necessity review, hospital day management, readmission management, value-based technology assessment, value-based benefits, performance assessment, pharmacy management, chronic. Every tool that there is being thrown at this problem with increasing intensity. And because of the private sector employers, you are allowing the people who work on your behalf to be even more aggressive. It used to be back in the old days, managed care. Back in the old days, people would scream bloody murder. Who are you to be interfering with me and my choices? How dare you talk to me as a doctor, and I'm the one that decides what's going on. Everybody was pissed off all the time at the insurance industries and the intermediaries. Now you guys are going, hey, look, you hungry? You tired? Can I put a towel around you? Go back in there, coach. You can win this game. You go in there and fight. You guys are not scaredy-fraidy anymore because you know your businesses won't survive if this stuff doesn't get a handle on. You've got to keep the pressure on. Unfortunately, if you saw the news the last couple of days, healthcare spending has now surged in the first quarter, and it's going right back up. It climbed at 9.9% annual rate last quarter, mostly because of increased spending at hospitals. The biggest jump since the 1980s, the third quarter. It followed a 5.6% increase in the fourth quarter. Further increases are likely in the second quarter coming up, in part because of the ACA's deadline was extended, and you're going to have more and newer people in, but you got a lot of people now who are starting to spend their money. You're also seeing dramatic price increases because of the increasing power of hospitals buying up clinical practices, especially oncology. So you've got oncologists that were working in the outpatient environment, and now they are being bought and moved into the inpatient environment, and the inpatient environment is charging you and others inpatient costs that used to be charged as outpatient costs. And they're fighting very hard on unit costs for the whole gamish. And this is a tough battle, and it's a tough war. Now, let me just say this. I like doctors a lot. I'm the former doc for the AMA. I like hospitals a lot, and I'm associated with hospitals. There are no easy answers in these things. There's no devil and angels. There's no good hat and bad hat. It's adult behavior in a complex market. Do you understand? It is a complex adult behavior. You have got to be on your game, though, and make sure you understand the forces that are at play. So everybody will behave as they should rationally inside of a marketplace. But what's going on is very powerful hardball as these kinds of monopsonies get created and bargain very, very difficultly. We're also seeing huge increases in costs because of things like the decisions made by the U.S. Preventive Services Task Force for lung scans. You've got to be attentive to these things. These are value-based conversations that America has to have with itself. Unfortunately, there are very few back fences to have the public discourse. This is a fundamental ethical issue that you have to think about. Should we screen all lung cancer people that will cost us $3 billion in new costs, on the other hand, may save us 20,000 lives for people that shouldn't have been smoking in the first damn place? These are tough issues. So that smoking issue is very important. I'll give you an even tougher one. The really determinant issue on healthcare's ethical agenda today, and it's the hepatitis C drug. And you probably heard about it. It's a drug called Sovaldi, and it has the ability to actually cure a disease called hepatitis C. It can cure it. It cures it at the cost of about $85,000. Actually more when you take it all in, $100,000, because you have to take it a little longer, a lot of people, than the original dosing. So it'll cost you about $100,000 for this drug. Simple math illustrates the challenge facing consumers, taxpayers, and insurers. If all 3 million people estimated to be infected with the virus in America are treated at an average cost of $100,000, the amount the U.S. spends on prescription drugs would double from $300 billion in 1 year to $600 billion. Already, these specialty drugs, which account for 1% of all prescriptions, but more than a quarter of spending. Other high-cost specialty medicines like this are in the pipeline. It's the tip of the iceberg. United Health Group, on its earnings call the other day, said it spent $100 million on hepatitis C treatments in the first quarter of the year, far more than it expected. But here's the deal. How do you get hepatitis C? Get it from drug abuse. So who are the most people that have hepatitis C? They're publicly insured people. So the great state of Wisconsin is going to have to make a decision. How do we handle this? By the way, if you don't give them the drug, people will lose their lives. They'll get bad outcomes. Their lives will be miserable. How does a mature society handle this problem? And I put that before you. Thank God you have the Alliance. The third, because you have a place to talk about it. The third big challenge is this storm of preventable chronic illness. I talked to you about smoking. I talked to you about substance abuse. Watch this. This is so cool. A tsunami of preventable chronic, I did that. A tsunami of preventable chronic illness is washing over a delivery system that we already can't afford. And you all know the chronic illness curve looks like that. There are a lot of sick people in America. It is an amazing thing. Wisconsin, we do something called the America's Health Rankings. I'm still associated with it. I love this thing. It's great. Go to the website. It's www.americashealthrankings.org. My young people that work with me hate it when I go www. Apparently that makes me an old fogey by definition. I say www. To give you time to get out your pencil So you can write down americashealthrankings.org. And I want you to go there. You have to go there. You cannot be an employer and not know what's going on with prevention in your community. So you will find out that you're the 11th healthiest state in the country in outcomes. Overall, you're 20th. That you will find out that you're 10th in diabetes, 30th in smoking, obesity, 35th. You got issues right here in River City. Okay? And now if you go to America's Health Rankings, then I want you to go to your local health department and get your local data for where your employees work. You cannot be an informed employer in this space if you do not know the epidemiology of disease in your environment. So smoking in the country is going down a little bit, thank God, but it's really bad news on the horizon. These e-cigarettes are terrible and are scary. We also know that 5.6 million children alive today will die prematurely from smoking-related diseases unless we can do something about this. They got these new products that they're marketing to our kids that are scary. Ladies, don't get mad at me. Don't get mad. This is what your children get when they watch the swimsuit edition of Sports Illustrated, and you go in there, and I don't know whether those in the back can see, and I don't want you to look too hard, men. But where the action is on that picture is a commercial for blue electric cigarettes. For blue e-cigarettes, right? I've got to get that off. You guys stop looking at that. Where the action, what do you think our kids are looking at? I mean, could you have a more obscene combination of exploitation of women and marketing of death and disease all in one particular picture? I mean, it's just, anyway, I have to go on. I get really pissed off with that. Can you be pissed off in Wisconsin? It's all right? Okay, thank you. Good. Could be like, religious thing, I don't know. Inactivity, gone down. Thank God, we're doing a little bit better on inactivity. We have something to build on. Obesity, no change. And then diabetes, no change. So we've got big problems. Here's the real deal. More Americans are living longer with cardiovascular disease, which will increase costs and lower quality of life. Cost of cardiac care will increase despite advances in prevention. What is it saying basically is this. We are making a lot of really sick people, and we will throw the entire armamentarium of Western medicine at them, and we will save their lives, and they will live longer. Thank God. We kicked death's butt. And we will never be able to afford to do it again. Because you just got to turn the spigot off. You cannot medicalize your way out of the chronic disease problem in America. You can't do it. We have to, listen, you guys at the Alliance, you have a lot of stuff on your plate. You have to do this work that you're doing, but please, I'm begging you, please put prevention on your agenda. You have to. You cannot insurance-ize your way out of this problem. Nobody can. So we have this organizing ethic for moving forward, the triple aim. Don Berwick, brilliant guy, and others have created this. Everybody can rally around. No matter what stakeholder you are in healthcare, everybody gets it. Let's do something. Let's improve the health of the population. Let's enhance the patient experience with care, moving up quality, access, and reliability, and let's reduce the per capita cost of care. We have to have disruption and transformation in our system. We've got to keep the pressure on. The Innovator's Dilemma, Clayton Christensen's book, it's a great book. If you haven't read it, you really should. You're private sector people, you should like it. Entrepreneurship, disruptive innovation is very important. Most other industries, most other powerful institutions that disrupted other industries did so by enabling a larger population of less skilled people to perform their work in more convenient, less expensive settings, and do things that historically could only be performed by expensive specialists in centralized, inconvenient locations. Sound familiar? Looks just like healthcare. Looks just like healthcare. And so you go back to the crossing the quality chasm. This is where that theology came from that tells you what you should be shooting for. Safe care, effective, timely, efficient, equitable, and patient-centered. This is where it said you have the way to get there, evidence-based decisions. Safety as a system property, continuous decrease of waste, cooperation among clinicians, anticipation of patient needs. Key. Patient as the source of control. Care based on continuous healing relationships, and customization of care based on the patient's needs and values. And finally, to get there, shared knowledge, and the free flow of information. Go to Crossing the Quality Chasm on your Google. Just pick it up and read the executive summary. You will be amazed at 2001 and how relevant it is today. And when you read those things I just went through, try to say in your mind, do a little checklist. How close did we come in the years that have intervened between here and then? And what do we have to do to get to where we're going? The Alliance agenda is absolutely connected to every one of the points that I've just made. That's why I'm glad to be here with the Alliance. Shared knowledge and free flow of information. Innovation in data and analytics is essential, and that is what's happening now. Finally, we in healthcare are in the era of big data. Big data that we now have to learn to aggregate and turn data into knowledge, and knowledge into value-added clinical judgment and cost-effective prevention management. I like what you guys are doing in Wisconsin. You've got a big head start over what a lot of other states are doing. You've got your Wisconsin Statewide Health Information Network with its tools and capabilities. This is very important. If you don't know about this, you need to lock in on this. Pay attention to this. It's important. It has a lot to do with what your agenda is. And a lot of states have not developed this, not nearly as far as you are. So you've got something that you can build on. America's Health Rankings, again, is a data engine, an aggregation engine that spits back, here's what you need to know, so that we can facilitate community-based conversations. Community-based conversations about health, community planning. So I've been going around the country trying to meet with business coalitions and trying to see, when I was at United, I would give out grants to communities to try to help facilitate conversations about health. Employers, you cannot work alone. You couldn't possibly have enough social responsibility agenda, or you can't go to enough Chamber of Commerce events with the golf tournament for the Little Sisters of the Saint elsewhere. You can't do it by yourself. You have to be bonded together. So we've been giving out grants around the country to places and said, look, how about if we just hire for you a planner to facilitate church, civic association, fraternity, sorority, employers, everybody together, using data about what's killing us where we live, combined then with recruiting new resources, identifying priorities, and working together on high priority issues that are causing us to spend our money in preventable hospitalizations, preventable readmissions. You understand what I'm saying? You can't do it alone. Please, you have to work together. We don't know nearly as much as we need to know about the link between public health and urban planning. Urban planning people are very important. If you give money to politicians, especially the local, state, people, get their urban planning people to come sit with you. Say, look here, we can talk about all that other stuff, the theory and about social reform and big political stuff and talking heads on MSNBC and Fox, and we can argue, we can fight. While y'all are doing all that, can we have the urban planner please come sit down with us and talk about creating healthy environments so that we have walking trails for people to actually walk and get this obesity thing licked? Let's make sure that we got something to do with food, because we notice now that when people don't have food and when their budgets for food expand, then their diabetes problems get to a problem because they are not able to afford to eat the stuff they need to eat to be able to handle their diabetes. All these things are connected. Data is very important for you managing your businesses, and I'm very excited about the new tools for you to be able to manage employee populations. Now you get in the maturation of real-time tools and advanced analytics to identify with much greater detail now what's happening in your employee base. And these are things that are just starting now to really take off. And I'm really excited by them as being an interactive capability to ask data. What are the health costs for my company? And being able to see, okay, I got a 4.6% increase in my cost, and why do I have that 4.6 increase? I can look at data like this that is arrayed and tells me not only the slope under the box as to how much I'm spending, but the intensity of the color to tell me the intensity of the change. So now I can really see this, I can move these variables around, but I can look and start to see that my real problem is with diabetes. So I look at my diabetics, I'm sorry for those of you in the back, but these are like 8 different cities that this company has plants, and up at the very top says Northeast Wisconsin. which has really got a problem with diabetes for this particular company. You know, cheese, who knew, you know. So, so you got, now you can start to look at those diabetics. How many of them are receiving the right care of that group? How many of them have a primary care doctor? How many of them have gotten their hemoglobin A1C3 checked? How many have had their annual creatinine test? Of those people who haven't gotten the right stuff, how many of them are empty nesters? How many of them are single? How many of those are married? What are the characteristics of those people? So now, instead of you sending out a brochure to the entire population on diabetes, you send it to northern Wisconsin, and you're sending it directly into the hands of the empty nesters, and you start getting very, so you don't have all the money in the world to just blanket everybody on everything. Now you start to being able to use data to get very specific about who your target populations are. Now we also have a revolution in data that tells us, hey, who's the individual inside of that? And now we've got this revolution in the internet and digital data as well as other forms of data. The revolution in the selling and distribution of things through the internet, Amazon and eBay. A revolution in the intersection of information and social relationships, Google, Facebook, LinkedIn, Twitter. And a revolution in the internet inside of things. Your Nike tools as you run, and there's the internet connected to your foot, the internet connected to your car. Ford Motor Company, car and tech firms working together to provide internet-based apps. Ford looks to introduce health and wellness apps in their car. Silicon Valley and Detroit are battling over the future of the internet-connected car. And now you get the internet inside of you. And now there's a company called Proteus that makes a fantastic new little wafer. The wafer is the actual size you see there by that pencil. It is a wafer that is made into a pill. You can manufacture these wafers so cheaply that you could put it inside of every pill. The wafer is biodegradable, ingestible, proven and approved by the FDA already. You put it's inside of the pill, and it signals when ingested, it turns you into a battery. And the battery then uploads to a wearable patch on your arm, and it tells you what was the dose, what was the medicine, what was the dose, when did you take it, right? All you need to know about that pill, we now understand. And now you can feed that back into a wonderful sorts of arrays that go uplifted to the data cloud in the sky. And it also not only tells you all that stuff, but because the patch has got an accelerometer on it, it tells you whether or not you got up and moved. Did you sit? How long did you move? How long did you sit? So you've got mama who lives in Florida, and you're here in Wisconsin, and you want to know, how is mama doing? Did mama take her medicine? When did she take it? Did she take 2 pills or 1 pill? And did mama get up and walk around today? You can do all of that today. That actually, this is not science fiction. This exists. So we've got a whole new set of data and analytic assets. It used to be that people that do this kind of work were pretty good at claims data, laboratory, and pharmacy data. And you could put it all together and tell a story about Jerry. Jerry is a 42-year-old, thank you, Jerry, 42-year-old male. And Jerry should have gotten his mammogram, but he didn't. Well, you know, I'm trying to make a story here. Jerry didn't get his mammogram, and we know it from the data. So you send out an outreach to Jerry, Jerry, get your mammogram. Jerry still doesn't go. You send out another email, doesn't go. Then finally somebody picks up the phone and calls Jerry. In other words, the data allows us to tell a story about a person and then check to see how well they do. Now that we're able to take health risk screenings, health risk assessments, health screenings, electronic medical record, health information exchange data, biometry data, mobile apps, coaching, all these kinds of things, put all of it into a soup, stir it up together. Now, this is very hard to do. Employers, we've got to be very attentive to advocacy for data and how data gets used. Now, let me tell you the biggest thing your employees are worried about, and you know what it is, privacy and security. People are terrified of privacy and security. So you've got a lot of work to do around this notion of trust. Trust is very important. People have to believe that you have really good mechanisms for safeguarding the confidentiality and privacy of employee information. They got to believe that every link in the chain is going to do that. If you are not attentive to trying to build trust, all the stuff I'm talking about will fall apart on its own weight. And so we all have to be very careful. We also have to keep producing these kind of very weird people who only speak the language of regression analysis and other things which I don't understand, to be able to take databases that were never intended to fit together and make them come together to be able to tell these complicated stories. But we analyze the data now, liquefy it, and now we're running all kinds of algorithmic rules to be able to tell you when the patient or when your employee goes to the grocery store and they got their smartphone and they go to reach for the Fruit Loops, that the thing vibrates and, don't touch that. Right? So we got a lot of to kind of get this down, but also giving it to the delivery system. But what's also happening, and this is key for things like PATH, which with the Quality Path Initiative that Cheryl talked about, is being able now to run multivariable analysis on how to engage people. We are living in a world now where we know who we need to talk to. We now know what we need to talk to them about. Bill needs to be talked to about something very different than Darling Darla needs to be talked to. They're very different people with different issues. We know who, what, but here's the thing that we've never done well in healthcare, and you do it better in your industries than we do. How do we talk to these people about their healthcare? People are different. I'm the former doc for the AMA. One of the things that I was supposed to do and was proud to do was to take care of the halo and the sanctity of the patient-physician relationship. Ooh. The patient-physician relationship. Ooh. And I love that stuff. It's one of the cornerstones of Western civilization. But here's the dirty little secret. Doctors are really not very good at talking to patients. Not nearly as good as Amazon is. Not nearly as good as iTunes is. These other industries are very good at talking to patients or talking to people in the way that they want to be talked to. So now we're in this world of wireless and broadband technologies, which is just terrific, enabling ubiquitous internet and email capabilities. We enabling smartphones. Like now, for my mother, if I want to talk to her, the only way to talk to her is by email. She's online with all these other seniors sending every dirty joke known to man to each other all day long. I had no idea. I thought old folks were not online. My mother lives online with all of her friends, and they do it. The broadband and wireless revolution gives us our smartphones with our personal digital devices that lets us do our texting. If I want to talk to my son, Lance, the only way to talk to Lance is by texting. I call him on the phone, no answer. Pick up the phone, call him, no answer. I checked the bill, I paid it, called him, no answer. Words came across my phone one day. I'd never seen words. I send words back, words came back. I send words, words came back. I picked up the phone and called him, no answer. Lance lives in a world of yes, no, and send money. It's very straightforward. As you see with my presentation, I've never met a semicolon I didn't like. I need nuance and subtlety. So that's the way he wants to be communicated. Lots of apps on our mobile phones now for healthcare. So meet Sam, he's a cook, 35 years old, struggled with obesity since he was a child. Currently taking antihypertensives and so forth. I know I'm overweight. I've always been that way. I'm not a joiner. I know I'm supposed to get follow my doctor's advice. I don't understand what she's talking about, and she scares me to death. And I'm just a cook, and I'm scared to bother her. I put off my stress test because I can't afford it. I don't know how much it's going to cost. I'm at my table on Sunday trying to pay my bills, and you tell me I got to worry about a stress test. I can't balance the budget now. How much is this thing going to cost me? So you give him an app now that he can then put in his health goals. All right, you want to lose weight? Cool. Now you lay out how much do you want to lose. Put your goals. Now connect with your boys online because his relationships are not geographic. They're internet-based. They're online. So you lay out your goals to your boys. You tell them I'm going to do this kind of a goal. I upload my data to my Fitbit, so I've got it in the cloud. I talk to my guys and tell them how well I did or didn't do. Now I notice I'm not making the progress I want. I want to talk to a coach about my behavior. You pick up the phone. You call a coach. The coach is sitting there saying, I'm happy to talk to you about your exercise and your walking and your weight loss thing, but the coach has got all the data about that dude and notices the real deal is he didn't get his hemoglobin A1C3 check, so I'll talk to you about your walking, I'll talk to you about your diet, but at the end of it, we're going to talk about getting your hemoglobin A1C3. you're living in a world where data is connected to personal engagement, reaching people how they are. You've also got this revolution in social networking, as I mentioned, but also in synchronous video communication. These cameras on these phones are so good that now we can actually have what? A clinical intervention with a doc online through a phone. And the technology is very good. And this is a brave new world of changing access all over the place. I will admit, I am the incoming president-elect of the American Telemedicine Association. And so I'm very, very intrigued by how we work through the reimbursement and licensure issues for these kinds of things. We're also in a world not only of broadband, but of sensors. This is the largest data source in the world. Sensor and based data, the largest data sources in the world. And so you get new smart Band-Aids. Put it on. This Band-Aid reads temperature and humidity and fluid, and it goes, excuse me, I'm infected. Help. It also sends out all your cardiac telemetry stuff, send it to the smartphone of the doc on the golf course. Now the patient maybe doesn't have to always be in the most expensive real estate in the history of the Western world called the intensive care unit, but maybe it can be someplace else, and we can start to monitor in a whole different, decentralized, disruptive way. Remote blood pressure monitoring through your iPad, and of course, people like me and others who every day strap these weird devices on, doing our exertion monitoring and uploading it into the sky. And then finally, you got this wonderful new revolution in gaming technologies. We tell our children, you will get a dose of exercise every day. Now, go exercise. You, exercise. Instead, you got this new Xbox Connect and these kinds of tools, Dance Dance Revolution. And now our kids can actually play with our family in the game room. We did the study, and you know what? Heart rate goes up just as much playing the game as if you get a dose of exercise. It's a whole new set of tools, and that's exciting. And then lastly, what you get is this revolution in the genomics. So we get all of our genome, personalized information to us. Here's the challenge for you as employers. All of these new tools, which are now unbelievably and unprecedentedly available to us to reach people, to change their behavior and to engage them, are all over the place. The challenge now becomes, how do we make it into human cognition? How does this stuff change actual behavior? And this is the exciting challenge that we all have today. Oh my God, this book. Who wrote that book? I've been very frustrated with barriers to care and excuses. Why don't people do what they want to do? Why don't they do as we ask them to do? And you know the fascinating thing to me is the whole book is based on the book's, it's give the book to somebody else after you get it. But the book's really value is the title, that look in the mirror. So take your left hand, like, and pretend it's a mirror. And you look inside of the mirror, you will see the best doctor that you will ever meet. After all, who knows you better than you? Who makes more decisions every day for your health than you? And who loves you more than you? Do you know that you all are so sophisticated that you don't need this lesson, but 90% of the American people are shocked that they can actually be the doctor in the mirror? You mean I can take charge of my health? You mean it's all right? The book is like a permission to people. You need to be in charge of your health along with your other doctors. And it is amazing that you give this book to people that are not as sophisticated as you, and they go, I can be in charge. I will be in charge now. And so it's fun. But I also look in there, I get very frustrated by barriers. Why don't you, everybody knows what you're supposed to do. Why don't you do it? You know why I don't exercise? It's too cold. It's too hot. I don't have the right gym shoes. I don't have the right workout clothes. It's too early. It's too late. Everybody's got a excuse. So I keep trying and everything. The part of the book I like the most actually is at the end, and that's about end-of-life care. I lost my son a few years ago, and I talked about it in the book because I really wanted to, again, get to this barrier of why people don't do advanced directives and why they don't do organ donation. So I learned and talked to a lot of people, so I put it in the book. And my editors told me, don't do that because it's a downer. People will be sad. And I said, man, I'm putting it in. I'm doing it. And most people, I've never had anybody tell me it was a downer. that it's a conversation that needs to happen in America, because that's a big area where we are just so suboptimal. So again, anything that this book can do to help you talk to your mother, your children, somebody in your, because you already know everything in the book. So what the book at least allows you to do, hopefully, is to help people to make the change. I also have something on my website that I've been really enjoying, and that is stories. And I would like you to send me stories if you just get a moment, if anything sparks you. It comes out of an observation. I was reading a book by Toni Morrison, the great writer, Nobel laureate, and she says, she imagined a brightness that could be carried in her arms and distributed, if need be, into places as dark as the bottom of a well. She imagined a brightness that could be carried in her arms and distributed, if need be, into places as dark as the bottom of a well. And why so dark? Because she was raped when she was 13, 15, 17, 19. We used to go, here's our brochure, just say no. There's no way that that message can cut through that much pain and heartache. Everybody has their stories. So I've been recruiting college students to write stories, the creative writers, to get them to write stories that give us some illumination into the process of trying to promote our health and restore our health. So if you get a chance, go there, read some of these kids' stories. They're unbelievable. They're really creative. But I'd love for you to share your stories with me and others who are reading it. There's a whole new science now of people that are trying to get us to thinking about how do we actually change behavior. We can't just assume, I'm going to give you this information and you're going to do the right thing. Well, it doesn't work that way. I'm going to give you the tools, and you're going to use them. We're going to put it on your iPad, your iPhone, and we're going to do internet, and we're going to do texting. But you still have to know something about how people think. Here's some of the people that are writing exciting things, important things. All I'm letting you know by this slide is that there's a whole nother army of people that are coming forward around this science of human motivation. Deborah Ness says something that I think is very important. I want you to read this. In the era of patient-focused care, consumer engagement too often means getting people to do what we want them to do, rather than asking them how to tell us how we can help them achieve their health goals. We need to change the culture. What can we do together to help them reach their? Would you please be this way with your colleagues? Okay? So you're sitting there with the data and you got all the smarts, but can you have a partnership with your fellow employees that says, hey, you know what? Your people that do this for a living want to figure out how we can work together. How can we help you do what's in your best interest? Because I know you're not completely stupid. You don't really want to die, do you? You really don't want to be in misery and pain and suffering. So let's figure out how we can have a conversation that works together. And so I'm going to skip this because I got to move quickly. But you can beg and plead all you want, but at the end of the day, value-based health benefits is going to be key, right? Skin in the game. People have got to have a financial skin in the game, and that's what's happening. And if they're going to have financial skin in the game, they have to do what Cheryl and the Alliance is saying you need to do, and that is you got to be able to make a difference on understanding the cost. So now, online, on your smartphone or on your iPads, there are people out here in the world who actually are letting you know, have the ability to let you know how much does it cost to go see Dr. Jones for a particular procedure. Real contracted rates. And that slide is kind of busy, but it's a couple of docs that are up there that you can compare. First thing you see is whether or not they are quality or whether they suck. Always best to know before you start looking at prices whether or not you have quality or whether you suck, right? Because the prices are not as important as whether or not the doc is good or whether the doctor sucks. Whether the hospital is good or the hospital sucks. Start with the quality, and then you worry about the cost. Please, that's always a good idea. But now you can see the difference between what their costs are, and then the consumer can look at the cost of the hospital, and then you can put the two together and then analyze it off a benefit plan and figure out how much it costs out of pocket. That's where we're getting to. Many more patients are using online doctor reviews to choose a physician, and what they will find, and have to be taught, be careful about U.S. News and World Reports. Just because somebody's got a good rep in U.S. News and World Report doesn't mean diddly squat. You've got to get much more granular. And that's why the Alliance's work is so important. Expensive hospitals, strong reputations, but little evidence of better care. We have to get better at helping people identify and access the best care provider for them. We've got to do a better job of getting the data, the numbers. How much does this stuff cost? We've got a ways to go. We're getting there. It's moving. Don't let up on the pressure. Demand to know the cost. You've got to know the cost so you can give it to your employees. Most states score poorly on price transparency. They don't do a very good job. Good news is we just had something that nobody's paid any attention to. It slipped in on this recent doc fix for Medicare, the SGR formula payment. And it slipped under the radar screen. And what it's now saying is that health insurers have to now report by code, when there is a code, that's another story I don't have time for, but to report by code when there is a code, how much they pay for lab services. Then Medicare is going to bundle all of that together and do an aggregate cost, a benchmark weighted average cost, and that's how they're going to reimburse people on Medicare side. I told you about those sledgehammers that are getting ready to happen to hammer down the Medicare expenditures. This is one of them. The lab industry is very, very concerned about this bill, and that's to be expected. So you're going to see a lot of those kinds of things. But then you got the Alliance's Quality Path Initiative. And again, this is a radical notion that you are actually going to guide consumers to physicians and hospitals that are working together to meet proven standards for delivering quality care and selected procedures. Please, if you want to act in enlightened self-interest, you really do want to join in on this one. And you're also going to have to figure out a way to talk to your patient, to your clients about this. You remember Angelina Jolie and her breast cancer experience. Angelina Jolie made an incredible decision about her experience with breast cancer. She used a test that gave her not a yes or no answer, but a probabilistic answer. Your chances are, statistics say that, and then she made a decision to have prophylactic breast mastectomies. How many people do you know in your company, women, actually have taken a course in statistics? How many people do you know are facile at handling probabilistic determinations on anything, much less their health? This is a really, really frightening future. And nobody is waiting for you to get your people ready for it. It's moving like a juggernaut. And so you're going to have a lot of issues. So the U.S. Preventive Services Task Force is now trying to say to women as clearly as they can say. Now, you wouldn't normally have the U.S. Preventive Services Task Force stuff on your desk. So I'm putting it in your head today. They're saying, okay, look, before you decide, dear lady, to get your genes analyzed for breast cancer, you're going to have to start with knowing what your family history. Because most of you all should not be getting the test that Angelina Jolie had. You need to start with your family history, and that's got to be very clear, because it's going to take you down all kinds of roads that you don't want to go down unnecessarily. And so there is an order to things that has to occur. And this one really scares me. This is a woman who had her DNA picture taken by 5 different DNA profiling companies, and all of them gave her different numbers, different stuff. None of this stuff is regulated. It's a complete wild, wild west. Can you imagine these folks now presenting to the doctor going, I want the Angelina Jolie test now? And then you start to, and can you look at what healthcare costs are going to be. It's going to be tough. Well, I'm going to end up here and just say the other issue, of course, that's driving change in is reimbursement and delivery system. Fee-for-service has got to die as an only way of paying docs in hospitals. Fee-for-service must die as the only way of paying docs. We've got to move to these new models. On the horizontal axis is, as you heard in the introduction, moving from fee-for-service to kinds of bundled payments to ultimately capitated and lots of stops along the way. And then on the horizontal axis, moving from solo Dr. Welby by himself out on the frontier to groups of doctors working more together. The stars are arrayed in different places to indicate to you there is no one size fits all. There is no one best answer. Full capitated is not the best answer in some places and the best answer in another. You're going to have different permutations of the model. But the point is, you've got to have value-based reimbursement to the delivery system. There's got to be a way that we are holding the delivery system accountable for its performance. And you're going to have a very excellent speaker as soon as I finish who's going to really take you through those things, who's an expert on how do you really think about this. So I'm going to not take any of the time from him to do that kind of thing. But just know that we're going to have to be evaluating these networks based on quality and then on price. And most of you are going to be buying benefits in the future that will say, I used to want a broad network, but now I want a smaller, high-performing network because I can't take the risk anymore of going to crappy doctors and crappy hospitals that cost too much money. That means you've got to be able to evaluate. You've got to put the pressure on evaluating. And on these narrow networks, they are pissing off everybody. Pissing off everybody. What do you mean I can't have that? And, and it's got to be a horrible political fight with Medicare. Look, folks, there are only so many tools in the toolbox. And this is one of the ones that's going to be very important. Doctors are going to have to step up and start to give us better criteria. And then we're going to have to be able to take the data like this and then deliver that data, that health information exchange data like you're doing in Wisconsin, and use it to integrate these pieces of a separate delivery system. Health information exchanges that pull this data together, analyze it, liquefy it, and then drop it back into the delivery system so that doctors who are now overwhelmed with the complexity of medicine and who are not making good decisions can actually have actionable intelligence going forward so that they will have, when a patient comes in, they will have an alert that says, okay, Mary Smith has a fascinoma. It's very complicated. This is what you need to know right now at the point of care decision. What diagnostic procedures are we ordering that we shouldn't, since we're liable for the expenses? What facilities are we using that are driving up costs? If I'm on the hook for value-based reimbursement, no longer in a fee-for-service world, I'm not sending my patient to man's greatest U.S. News and World Reports hospital anymore because it's coming out of my pocket. I'm sending you to the best quality and the most efficient. No more fooling around with this stuff anymore. So now we will have data that's transparent right there. What's driving up my costs? And then how do I connect with public health on the prevention side? Now this is the one that's really interesting. Look at this slide. 50% of last year's highest cost claimants used less than $5,000 of health care the year before. 50% of the highest cost claimants used less than $5,000 the year before. What does that mean? It means the delivery system doesn't know who's getting ready to be sick. So doc walks in the morning, goes over to the desk at the front of the office. Nurse Ratchet, who's here? Okay, put this one in room 3, this one in 9, this one in 12. That's the old day. Now the new day, doctor walks in. Nurse Ratchet, who's here? Got the list. Then he says, excuse me, who's not here that ought to be here? Who's the person that's about to tip and be sick as hell and cause us to go bankrupt? Who's the one we got to reach out to and pull in here and deal with them while we still have a chance to get the disease from going from, oh my God, to we can handle this? And that's a new way that we have to start to think. So it integrates the value-based health benefits and it integrates the value-based reimbursement. And to that, finally, we align value-based technology assessment. And I told you about that big drug for hepatitis C. How well do we evaluate? And how do you write benefit designs that tell the people who are your intermediaries what you're willing to pay for? I'm going to pay for this hepatitis C or I'm not. What are the criteria? So, what are the things in which we will evaluate innovation? What are the criteria that we will use? Because the people who act on your behalf have to know what you're buying. They have to know what you want. And so benefits are going to have to be tied very clearly to technology assessment. And you're going to have a lot of faith in the people who act on your behalf. This is a very complicated world. And the people who do your bidding are having to enhance to a significant degree their technology assessment capabilities because there's too much money at stake. My last slide is there's also this interesting world now where we're trying to pull together the clinical medicine system with the public health system. Here's a kid with asthma. He's a good kid. Got the delivery system saying, I'm going to take more responsibility now to how to keep this kid out of the emergency room because it's generating too much costs. And it's on me when I generate costs, so I don't want to do that anymore. So basically, they work hard with mama to teach mama how to teach the kid to use the inhalant. And we do a real good job now. The delivery system saying, I think we got to be open on, after 5, so that the only choice they have when they get asthma attack is go to the ER. So we're going to try to have extended hours. We're going to do all that stuff. And the hospital is going to do what it can do to make sure that it is being as responsive as possible. But at the end of the day, somebody's got to deal with the mold and mildew in the heating duct and the air conditioning system that's the allergic precipitant to the asthma attack. We got to turn off the spigot. And so public health is going to have to start to have a new relationship to the delivery system as we put it all together. Ladies and gentlemen, you've been very patient. I'll see if there's a couple minutes for questions, but we are in a volatile, unstable, and risky environment filled, cleverly disguised with opportunities everywhere. I asked you to listen to a lot delivered in a hurry. I wish I could make it simple for you. I wish I could sugarcoat it for you and say, okay, the solution to all these issues that are before us is just one magic bullet, and there it is. You want to know it? Plastics. You got it? Plastics. That's it. See you later. It ain't easy. You can't do this by yourselves. You have to be in coalition. You have to be in the alliance. And the alliance has got to be empowered and energized to be the fulcrum to help you to work through all of those things. I wish you well. There are a lot of your friends and colleagues and neighbors who are absolutely and totally depending on you. Do not let your foot off the gas. Do not let the pressure get turned down. Thank y'all. Do you have a minute for a question?
Yes, let's take 5 minutes. Are there questions?
Or differences of opinion are good too.
Yes, 3 microphones.
I'd rather hear the difference here than in the hallway or the bathroom. The women's room, I don't know. Y'all can just talk about me like a dog. I will never know.
And please give your name when you ask your question.
Yeah, my name is Tom Hirsch, and I'm a medical advisor for the State of Wisconsin Department of Employee Trust Funds. And I enjoyed your talk very much. I think one of the things that continues to be a major problem for us with the healthcare system is that we continue to provide care to patients that if the patient were better informed, in many cases the patient would say, this is not in my best interest, this is not cost effective, this is not where I want to go. We don't want to be doing surgery on patients, for instance, who if they were better informed would not want to have that surgery. So I think there's a lot of wonderful new stuff out there, but trying to really pursue shared decision making and advanced care planning is a fairly low-tech way to have a very profound impact on our costs as well as quality of care. So I really think that buyers have got to insist that the payers that they are associating with, or if they're self-insured, there has got to be credible shared decision-making programs and advanced care programs that can be monitored and can be well described. This can really have a profound impact on all of us, and it's without an insurance company saying no. It's about patients saying, this is what I want, now that I'm well informed.
So the exciting thing about this extremely articulate and perceptive comment, which I would just put a frame around it and light bulbs to glow all over it, is that it not only sounds right, but it's true. So we do know from studies that patients who are given the right information, as Cheryl said, at the right time, given the right information at the right time, will almost always avoid the dumb thing and do the most personally appropriate right thing, especially as the example that he used, which is surgery. Very, very important. I also like the comment around low tech. That's why you saw all those slides I was giving you, and so many of the slides I'm giving you have to do with how we communicate with people. And that's why, for example, with the end of life thing, I put my son's death in the book. And the reason is because it is low tech. You have to give people permission that says it's okay to talk about these things at the end of life. What does mama want? How does she want it? And basically using the phone to get everybody together, especially crazy Aunt Sue, who lives in who knows where and who only descends at the last moment, who didn't know mama at all over the years, but has decided, we're going to do everything for her, I don't care what. And everybody goes, man, where you been? Get out of here.
Yeah, thank you. Thanks for the talk. I think that's working.
You're working, yeah.
Dr. Tuckson had a book up there called Switch by the Heath brothers. And I'm Matt Vanderkoy from New Life for Work, and we work with companies. And what we're seeing is a phenomenon from that book, Switch. They talk about change occurring, first of all, when emotions are engaged. And what's happening with that high deductible health plan, which is good for skin in the game, is taking emotions and they're engaged. Fear, sometimes anger. And what we're seeing is two things. One, we're seeing employees taking that new responsibility and doing responsible things with it. But we're also seeing employees have that fear, and their change is they're totally disengaging altogether from, I'm just not going to take care of anything. So what's essential for employers, I think, in this marketplace is that they are really trying to provide information to their consumers on what to do with this newfound responsibility, because they don't know yet. And they really need to know what's the right care,
Good for you.
what's the right cost, what's the right time.
So what I really like that both of these first questioners are doing, and I couldn't be more pleased, is that they really are at the heart of the presentation, which is it's the marriage of the very technical data and information with how you have the conversation. And you've got to do both and stick both together. And that's the key. What you have are intermediaries who will take care for you of the technical. What you can do, in addition to insisting that the technical be taken care of, but what you have a unique opportunity, which you may not be using to the maximum right now, is all of your communication and engagement resources with your colleagues to have the conversation. How do you help them to think about it in a non-punitive, pejorative, finger-wagging? No, it's not this anymore. It's what did Deborah Ness say? It's how can we help you to think about what you want and get to your goals. It's the combination of the data, the science, and how we think.
My name is Mike Hessler. I'm an independent agent with Robertson Ryan. Dr. Tuckson, how do you see the cottage industry of direct primary care or concierge medicine fitting into a potential solution for the shortage of primary care doctors?
So, great question, thank you. First of all, I believe in the free market. I believe that people ought to be free to make the relationships that they want. I believe very much in fluidity and meeting customer demand. I believe in disruption, and I think disruption is good. So if there are people out there who have figured out a business model to meet the needs of individuals and have a new idea of how to do it, and they can succeed in the marketplace and add value, terrific, good on them. I don't see how you scale that thing big enough to be able to do all the stuff that we're doing. So it will be, as you say, a cottage industry. It will be a niche. I don't like to watch that show on TV with the guy in the Hamptons. What is this thing called? They got the TV show where the doc is in the Hamptons and he's the concierge doctor, the rich. Anyway, I'm glad y'all don't watch it either, so good. It's on prime time, is every time I turn on I see this dude. Royal Pains. I don't like that show because I'm much more of a person that spent his life worrying about how all of us are going to get taken care of, not a bunch of rich people who got their own doctor. So it kind of irritates me from an ethical point of view. But the bottom line is, ultimately what I'm saying is, there will be people that will figure out how to do this without insurance, who will basically take folks who got a lot of money and will say, okay, I will give you all this money and I'll get this very personalized care. And that works for some people. That ain't got nothing to do with the 99.9% of the rest of us who've got to solve this stuff at scale. And so good on them, good luck to them. And also what I do hope that they will do is that they will raise the bar of customer service and raise the bar of expectation so that everybody's got to change. Do y'all have this cab company, Uber? Do y'all have Uber here?
Sore
Anybody have Uber?
subject.
Huh?
It's a sore subject.
I know it. I can imagine. And that's the point I'm raising it. It is a sore subject. If I talk to a lot of cab, because I travel all the time, and I'll end up with this because I know we got to go. I travel all the time. And I'm always talking to the cab guys. How do you feel about Uber? And they just, then they crash the car, But at the end of the day, they are using these new technologies to disrupt things. When I've used Uber, it works like a charm. I mean, and it's so much cheaper. I don't know how you make money as a limo driver anymore with these guys there. I mean, it's painful. My point only is they are ramping up, though, the level of customers. So even though I don't like it, it's changing the dynamic. The concierge people, I may not be comfortable with them. It's changing the dynamic. It's making everybody get, if you are not skating to where the puck is going to be, you will get disintermediated. And that's the deal. So unleash 1,000 flowers of innovation. Let the winners win and the losers too damn bad. Thank you all very much.